We're now going to hear from Laura Wade-Gery, who is the chair of Moorfields Eye Hospital, a really fine institution where there has been a huge amount of innovation in recent years. You're most welcome. Thank you so much.
Good afternoon. It's a pleasure to contribute to the continuing story from this morning and try and show you, I think, some NHS innovation that is at the point of scaling would be my first point. To pick up some of the things that Dominic talked about this morning and talk about the fact that I think the barriers are real, but I believe they can be overcome. And I think my third point is we should all care about this because of the reasons announced this morning, and then parochially for eye care, it's actually ophthalmology is the single biggest specialty on that waiting list. So that kind of 7 million, the biggest constituent is eye care. So those are kind of my 3 points. I've come to Moorfields with a background from the private sector. So I guess I'm an innovator in some ways. I grew Tesco.com. And in fact, I was involved in Clubcard back at Tesco in '97, doing exactly what you were talking about with data there. So that, and I came to Moorfields because it is a specialty, eye care is a specialty which is entirely driven by images and is therefore really ripe for digital transformation and how we can change pathways. So I think it's a very exciting place. She says, press the right button. So I've already explained that eye care is the biggest specialty. Interestingly, losing your sight is the thing that people fear most after getting cancer. So and we already have in this country 2 million people with impaired vision, and that number is expected to double as we see an aging population coming through. And sadly, even in the UK, even in London, we are seeing avoidable sight loss take place each year, basically because we don't get to people soon enough and we don't recognise the symptoms that can be treated. So innovation in our pathways is really important. You'll have heard of Moorfields. I think the thing I wanted to underpin was our strategy together with our partner, the Institute of Ophthalmology, part of University College London, and our eye charity. We are trying to essentially get, particularly from data set to diagnostic, faster. So bench to bedside, but particularly in the data space, because we think that's the place we can make a really big difference. Helpfully, for what I'm going to talk about, we actually have quite an unusual footprint. So many of you may have seen or indeed visited our City Road headquarters, but in fact we operate across 21 sites in London. And so it's Moorfields at St George's or Moorfields at Northwick Park. And we're now also powering, using our virtual A&E, all the 111 referrals in London come to our virtual A&E. And I think I've already referenced the all our subspecialties require imaging. So we've got a kind of, that's pretty unique in terms of a specialty that's susceptible to essentially taking a picture and then asynchronously diagnosing what's required. So you don't need the consultant at the same time as you need the patient. The other thing that was very helpful from our point of view in terms of our innovation backdrop is that for a long time, this being the NHS, we have been planning to relocate to up near St Pancras, and that's due to open, and in fact we've reached the 8th floor, so the building is nearly complete, in 2027. And because it's actually a smaller footprint, we had to think all the way through the teens when the kind of momentum was gathering to find the funding and the approvals about what pathways would look like in a smaller footprint. And so that backdrop was immensely helpful when it came to the pandemic, because we had already got a whole lot of thinking about how to innovate. I think this morning we heard about the traditional service model. So Ian was talking about it probably hasn't changed since 1860. So you get diagnosed in a variety of different places, predominantly in eye care, optometrists in the high street or your GP. You get referred frequently to the wrong place in secondary care because people don't know what it is that you've got. You then hang around in an outpatient setting for time that isn't best spent, and there's not necessarily very good continuity of care. So what did we do both before and during the pandemic that we've now brought together? So we experimented, first of all, with virtual A&E. So as the pandemic arrived, essentially we introduced, using Attend Anywhere, the ability to go online and be instantly helped in an A&E context. And we've kept that going. So it's now had 45,000 people use that, 5-star rating from over 95% of people. And actually, what's really interesting is only half of the people who bring it need to come to hospital at all, and only 1 in 5 actually need treatment that day. So you can instantly triage away and back into a more appropriate setting a lot of care. As a sort of little aside commercial, that service, we're technically only commissioned to provide that service in London. In practice, should you find yourself with an eye emergency anywhere in the globe at any time, if you go to the Moorfields website, you can access our A&E service. Just so you know. It's useful to know, I think. The second thing I'd highlight on this slide is our diagnostic and monitoring hub. So I think there was some talk this morning about sort of moving care into smaller settings. So one of the things we did in COVID was open in places like Brent Cross Shopping Centre the ability to go and get all the eye photography and tests that you need in one efficient setup, and do that in half the time it would normally take you in an outpatient setting. And then we diagnose that centrally and determine what treatment you require. I'll come back to the statistics about that in a second. So then what we've done is we've taken those experiments and we have essentially developed a completely different integrated digitally enabled pathway. And it's both the pathway we're using at Moorfields and it's also the national eye care pathway. So I'll just walk through the different elements of it. The first is that instead of GPs being in the loop, essentially GPs have been taken out of the loop and optometrists can refer directly to secondary care. Not of itself a hugely helpful step necessarily from the secondary care perspective, because you may get all the wrong referrals, but it has made a difference in primary care. Secondly, I've talked to you about the fact that for A&E care, we've got this model of Attend Anywhere, and a large number of patients don't need to come the same day. The third piece is a simple phrase that actually can mean a lot of different things, but is I guess, the key single ingredient, which is the single point of access for all referrals. And so what we've done is experiment in North Central London's integrated care system, and we've now been commissioned to provide this. But we essentially experimented with taking every referral from all the optometrists in that area, and we took that and then digitally, assembling that all digitally, clinically triaging it and sending it to the right place. So we took the time taken for triage down from an average of 11 days to 2 hours. We have then, in many cases, actually, they don't need to be, they were being wrongly referred in the first place, so they've actually stayed and gone back to optometrists for care. And we, sorry, I'm trying to get the rest of my, yes, and then I'll bring that here. Patient journey down, yes, 3.5, and then the other point about it is that we see people in, no, sorry. I'm back on my single point of access. we send it to the right place in the first place, which reduces all that moving around you had of people going to the wrong place. And then the final element is the fact that we frequently then get their diagnosis confirmed in a hub where we are doing it at great speed and with considerable efficiency. What the interesting thing is that 3 in 5 of the people who now come to those hubs actually stay in the hub. They don't need to be seen by a consultant at all. So we've removed the need to see a consultant in this outpatient journey in 3 in 5 cases. So these are long-term conditions that are being efficiently monitored in location. That very structured pathway also then enables us to apply AI to different stages of that journey. So some of our researchers pioneered with DeepMind in the late teens the use of AI to triage for a whole variety of different signs of eye disease. And we think that we can deploy that both out in optometrists and then potentially in these diagnostic and monitoring centres. Summarising, effectively we get a more than 50% reduction in face-to-face outpatient appointments. And then we have managed, because we've used this model, to actually we will be back within the 18-week waiting list for all our patients this year. And that will be pretty much the first people to do so in eye care. So we're reducing avoidable sight loss. The opportunity is to take this from the 1.5 ICBs that we are currently doing it in to, first of all, the whole of London, and then potentially a broader footprint. So we're in discussions, as you heard from Dominic, about taking London as a whole, to actually take the proven model that we've demonstrated in eye care, do that first, and then the second point is potentially apply that to a series of other specialties where you can achieve the same results, we think. So that's the sort of, I guess, innovation in practice in the NHS, I think a success story, beginning to be scaled, and I'm optimistic about how much further it can go. Thank you very much.
The Harley Street Health District, the home of healthcare since 1860.